Hi, everybody. It looks like we are live. So welcome to Ethics Awareness Week 2020. Thanks for joining us. We have a great Okay, it sounds like I'm echoing, so I'm going to close down my YouTube live. Hopefully that will help. All right, how's this? Is this working? Give me a thumbs up, people, if it's working. Okay, thanks. Okay, so welcome to Ethics Awareness Week. Thanks for joining our health professions and COVID-19 panel today. So COVID-19 is obviously a really hot topic that's affecting a lot of us right now. And so we're going to be talking about some ethical issues surrounding that from various professions, including nursing, dental hygiene, public health, and respiratory therapy today. So my name's Sarah Hall, and I'm an assistant professor in the Department of Public and Community Health here at UVU. I'll be moderating this panel, and hopefully that I do a little bit better than Chris Wallace did when he was moderating last night. I think it's going to be great. And we're going to start with nursing, then we'll go to dental hygiene, public health, and respiratory therapy. And we'll also be doing a question and answer at the end. So you should be able to submit your questions through the YouTube live link in the chat box. So if you have any questions as we're going through the panel, just feel free to type in that question, and we'll have Marcy Henley collect and ask those during the Q&A session. Without further ado, let me introduce our panelists today. So we have David Keller in nursing. So David is an associate professor in the Department of Nursing at UVU. He's been a nurse for more than 40 years, and he currently teaches mental health nursing, genomics in nursing and health, and clinical assessment and reasoning. David wishes he had asked his grandparents what life was like during the 1918 to 1920 influenza pandemic. Then we have Karen Preston in dental hygiene. Karen's an associate professor in the Department of Allied Health and Dental Hygiene at UVU. She teaches many of the STEM courses in the dental hygiene program, hands-on instruction in the dental hygiene clinic, and online courses in the dental hygiene bachelor's program. She's been a practicing dental hygienist for over 35 years. Next, we have Sue Jackson. Sue Jackson is the department chair and a professor in the Department of Public and Community Health at UVU. She teaches courses in epidemiology and biostatistics and has assisted in university COVID decisions. She is currently helping as the COVID response liaison for academic affairs, tracking positive student cases by class, major, and building. Then we have Kim Bennion in respiratory therapy. Kim is a part-time instructor at UVU in respiratory therapy and the corporate administrative director of respiratory care clinical services at Intermountain Healthcare. She and the respiratory care leadership team led many key aspects of Intermountain Healthcare's COVID pandemic strategic planning. Okay, again, for the audience, don't forget to submit your questions through the YouTube live chat box as we're going along, and we'll ask those questions. So we're going to give each of the panelists about 8 minutes to tell us some important points related to COVID in their profession, and then we'll do about a 15-minute question and answer at the end. So let's start with David.
Thank you. I appreciate the opportunity to be part of this panel discussion. I never asked my grandparents, who were in their late teens or their early 20s at the time, what it was like during the time of the Spanish flu, because I never thought that we'd see anything like this again. I thought that was a one-time experience. It actually might be fairly similar to what we're experiencing now. And one of my favorite quotes is from a historian. Actually, probably multiple historians have said similar things, but Weber said, in the end, one thing that we learn from history is that people seldom learn from history, even when they pretend to do so. So I'm going to do a little bit of history and talk about some of the current situations. So I'm not on the front lines of the coronavirus battle like some of my nurse colleagues, and I get to do most of my job duties from the safety of my home. I have access to reasonably good health care and even a small pension from previous employment that makes me feel just a little bit more secure. But I also have connections to people locally, family members and acquaintances who have been much more seriously affected by the virus. I know people in Northern Italy, in New Zealand, in Peru, who have been in very strict quarantine conditions with horrible things happening to their neighbors. And I know of one nurse in Peru who has to pass through 3 police checkpoints to get from her home to the hospital where she practices. So there are other highly impacted communities that I'm concerned about too. I have connections with the Hispanic community here in the Utah County area, and they have the highest infection rates in Utah. I also have connections with the Navajo Reservation. I grew up on the border of the reservation, and their infection rates have been as high as they ever were in New York City at the worst. And they've undergone 54-hour weekend curfews for several months. They just recently quit doing the weekend curfews. So let's talk about some of the ethics and issues and what happens. But I do have a conflict to disclose, and that is that I have a very ambivalent relationship with philosophy and including ethics. I took a medical ethics course in 1978, and we had this beautiful book with all kinds of readings from various authors on issues, ethical issues in healthcare. And it was very disconcerting to me because most of the students really liked the articles which used very clear logical reasoning to make ethical decisions in healthcare. Whereas I found those articles simplistic and unrealistic. I liked the articles that very deeply explored all aspects of the ethical dilemma and didn't necessarily even come to identifying the one ethical way to respond. So I knew that those authors felt the distress of moral values in conflict in real situations. And my classmates thought those articles exemplified fuzzy thinking. So in real life, ethical values and issues are very messy. And my experience is the person who claims to know the one ethically correct answer to a dilemma probably doesn't really understand the situation. So some of the values that are of importance in nursing in our profession is we feel a strong duty to care. We have a responsibility because of our education, our license to care for others. We also feel compassion and respect for every person, and we respect individuals' autonomy. We believe in fairness in providing care, and we believe in fairness in allocating our resources. We also believe in promoting community health and health globally. And we also have to remind ourselves sometimes that we have a duty to take good care of our own health. So as we see nurses on the front lines around us being described as heroes lately, and being given free meals and all kinds of things, the honking salutes in the hospital parking lots and all kinds of things like that. We're, as nurses, we are feeling some moral distress. And moral distress is probably best described as the feeling we get when we're prevented from being able to do what we think is right in the situation. So things that produce moral distress are when we have limited resources or don't have access to our usual resources to do the usual kind of care that we provide. And that also results we also get moral distress from changes in the standard of care. We cannot do what we used to do when we get into disaster and crisis situations. We have interrupted patient relationships. We're not able to connect with them the way that they need for us to be most helpful. And we find ourselves working in unfamiliar environments, and we have a lot of uncertainty about, okay, how does this disease progress? How is it transmitted? So what I'm seeing in my colleagues and what I'm reading from around the country and around the world is very much like what I've been reading about in a study done with US military nurses on the ground during the Vietnam War, who were not able to do things the way that they thought they should be done. And they felt distress, especially when a whole group of severely injured people came in, and there were some that they just knew that they could not help because they had to use, using the utilitarian approach and make sure that they were doing as much as they can for as many people as possible. So a lot of our nurses today are feeling that too, and it's a real difficulty. One of the biggest issues, though, is the idea of polarization. In our society, I'm not sure why the pandemic has polarized our society, and I'm not sure why it has become a political issue. One of my nurse colleagues told me about a woman who told her she hated maskers, how they shame anti-maskers. And then she called my friend, the nurse, a sheep because she was wearing a mask in public. And my nurse friend said, I'd rather be called a sheep and show others that I care by wearing a mask. And the other woman replied to her, no, it only looks like you care about people. So I'm really concerned about the degree of dehumanization that we're experiencing with the polarization and politicization. I hope we can learn from history. I hope we can learn from our colleagues around the world. I hope we can learn from discussing our values and our resources and the inequities that exist. And I do hope that my nurse colleagues can continue to take good care of themselves. Thank you.
Okay, thank you so much, Dave. So next we're going to have Karen from Dental Hygiene.
Good morning, everyone. I'm really happy to be invited to be on this panel. I think it's really important to talk about COVID and how it has affected, especially the healthcare, since nursing and dental hygiene, public health, we're all in the same boat. But dentistry poses a little bit of a different challenge. Dental hygiene and dentistry are considered one of the highest risk professions to be in. And it's because that we work so close to the mouth. We work about 15 to 17 inches from the mouth. In our clinic here at UVU, the students are with the same patient for 3 hours. In private practice, they are with the patient for about an hour. And so during that time, it's a very intimate contact, a very personal contact, close contact with patients. So a little bit of history on when this COVID hit. Right after spring break, our university rolled online. So that meant everything we had with clinics shut down. So no more clinic for UVU, and I would say the majority of dental offices also shut down. And they shut down for about a month. But they started to open up, and they started to open up with protocol. And so there were certain steps to open back a practice to bring patients in. The only practices that were really open were practices that dealt with surgeries and emergencies. So if you had a toothache or you had a gum infection, something, an abscess, something like that, then you would need to see somebody to take care of this, because it is unethical to not see that patient who has a problem, because any one of those things of mouth infections can go systemic and affect other areas of the body. So with that in mind, they opened up on a very limited basis to see these emergencies. But during the summer, practices started to open up. They took in the protocol of, they upped our PPE, our personal protective equipment. We had barriers between front desk and patients. Patients weren't allowed to stay in the waiting room. They waited outside until called in. All books, videos, toys for the kids, all of that was stripped from waiting rooms. So that was cleaned out. So there was nothing there to really touch or handle. All patients are screened with a questionnaire and a temperature check. And this is done not only in our clinic here at UVU, but just across the board with offices that are very concerned about this COVID virus. And to mention back to how close we work with the patients, this virus has been known when you inhale it, it attaches to mucous membranes. And so that includes your nose, your mouth, all of that. That's really in eyes. That's really a good portal for the virus to enter the body. So what do we do then? As people in dentistry, what did we do to change it so that we could actually open a practice, open our clinics, be ethically sound in treating the patients that we see? So we don't see patients that are symptomatic. We actually, when patients are in our clinic, if they have to use the facilities here within the HP building, they have to wear a mask. We give them a mask, they walk down the halls and they come back. The patients are immediately put in their seat and no waiting in the waiting room. And so we've had the biggest question for our field is been our instrumentation. So of course we sterilize our instruments, but there's one instrument we routinely use in dentistry, and that is the ultrasonic. And the ultrasonic is one that sprays fine particle mist in the air. And those fine particles can stay in the air for hours. When they're big enough, they drop and land on the surfaces like your surface countertops, your doorknobs, those kinds of things. And so with that in mind, at first we thought, well, maybe we won't use ultrasonics. But then is that really a good idea not to use? Because it really is for the benefit of our patient, for the health of our patients that we use these. It not only helps us get through our appointments, but it helps knock off large amounts of biofilm that the patient has. And so it's a very important tool. So how we worked around this is we had a colleague which came up with a really good idea. And this idea was to make a third arm or come up with a suction, because dentists use high speed as well, drills and high speed suction, and they have an assistant that helps keep that area cleared and things out of taken out of the mouth that are, high speed evacuation have taken down. But dental hygienists don't use high speed. They use only slow speed suction, the little thing they stick in the mouth and it sucks out the saliva, and it's called slow speed. We don't have high speed evacuation. So what we did is one of our colleagues developed what she calls the dental flex arm. And I like to call it the third arm, but the dental flex arm. And it's a thing that sticks to the back of the chair and it comes around with the high speed. If I can share my screen a little bit with you, I can show you what this looks like. If I can find it here. Getting that up there, yeah, okay. Can you see it yet? Okay, can you see this now? I can't see, I can't.
I can see it.
Okay, great. Okay, so what this is you can see on the back of the chair, a little suction cup here, and this suction cup sticks to the back. And this here is the arm. It comes around to the high-speed evacuation tip right here. And this is our high-speed evacuation hose. And here you can see our student. She is using the ultrasonic, which is right here, and then the high-speed suction that comes, the arm that comes up here. And here's the suction. You can see it sucks very close to the mouth. She is also in all her PPE. She has a mask on. She has glasses on. She has a visor on. You can see that everything in our operatory, as far as surfaces, the chair, the cart, there's also a radiology head in here that also, like in this other picture here, has a cover on it. So everything has a barrier of some sort to help protect any of the spray or splashback on that. And so that's been a very creative thing that our colleague has come up with to help with the aerosol part of that. So yes, so now we say, yeah, we are using aerosols. And some of the studies that have come out with the aerosols have not really tested in a dental office. It's been in controlled labs and controlled environments. They haven't really come in and say, I'm going to do this test. So I don't have a lot of data that says that, yeah, you can get COVID from the dental office. There's no data out there that suggests this is where people are picking up COVID. So we feel very comfortable and very safe when in our environment that we are protecting ourselves as clinical workers and that we are taking care of our patients, that we have cleaned with a surface disinfectant that has a good kill load when it lands on the surface. We let it sit and then we wipe. We also use a pre-rinse on our patients, which hydrogen peroxide's in it, which is geared for more viral viruses over bacterial for oral cavity for the microorganism load in the mouth. So that helps with the pre-rinses. So we've really tried hard to bring our services to keep the health of our patients with their mouth here at UVU and also in our dental offices around the area. So I appreciate you listening to this and getting to understand a little bit more of what goes on with dentistry and dental hygiene here at UVU. Thank you very much.
Thank you, Karen. So just a reminder for anyone who came in late, feel free to submit any questions you have through the YouTube live link, and Marcy will be collecting them for our Q&A session. All right, next up we have Sue Jackson from Public and Community Health.
Hi, everyone. Happy to be here with you. I gave a lot of thought to what I want to talk about in terms of COVID and Ethics Week. And here's what I came up with. I want to talk today a little bit about kind of the bigger picture, not really the ins and outs of the virus, but the overarching theme. So one of my favorite quotes, and my students have heard me say this a lot, C. Everett Koop, who was a Surgeon General in the 90s, and he said, health is not a moral issue. And so he said, it's not about whether it's right or wrong. It's about whether it's healthy for the person. And so this was the 90s. We were talking about safe sex. We were talking about needle exchange programs. We were talking about some of these behaviors that the general public did not find moral, but yet we're trying to protect their health. So better to give them a clean needle, even if they're a drug addict, than to have them get disease. So I want to build off of that and say that I think that 2020, we need to say health is not a political issue. That's the message I want to talk about with Ethics Week today, is health is not a political issue. I want to talk a little bit about the Centers for Disease Control and Prevention. They're located in Atlanta, Georgia. That is the nation's premier public health center. And they are under the direction of the Department of Health and Human Services. So that's kind of where they fall in the hierarchy of it. Their goal, and I'm going to read this to you because I want to make sure I get it word for word here, to protect public health and safety through the control and prevention of disease, injury, and disability in the U.S. and internationally. So I think this is really interesting that not only is the CDC the U.S.'s response to any type of public health or safety concern, but it also serves as an international resource. Because we have such a large public health resource, that is actually an international hub for information as well. Now, the CDC is not a small organization. In fact, they have campuses in Atlanta, Georgia. They have 15,000 employees and contractors, and their budget is $11.9 billion. That's their fiscal budget. 2018 is the latest I could get on that. Now, I mentioned they're located in Atlanta, Georgia. If you look at the history of the CDC, they were set in Atlanta in 1946 because of malaria. And so they were the first to really look at malaria issues, and it was the South that was having issues, which is why they were headquartered in Atlanta. Now, this serves to be a disadvantage politically for the CDC because they are not in DC with all of the policymakers and legislators. So they have kind of a disconnect. They have a small office in DC, but their main headquarters is in Atlanta, Georgia. So they have that diminished influence in Washington. The CDC director is also one of the only public office directors that is not Senate approved. It's either a career employee or it's politically appointed director into the CDC director. Now, the reason I give you all of this history is because I want to talk about what's happened with this pandemic. Early on, I've been in public health for 20 years now. Early on, I talked to my friends in public health and we said, where's the CDC? They were largely absent in the first few months in giving direction. And since then, there have been several moves that the CDC has made that the general public health professionals do not agree with. And so it's talking about that political influence. I want to give you a couple of examples of things that the general public health profession does not agree with the CDC on. One of the first ones was when they came out and said those who were exposed to COVID and non-symptomatic didn't need to be tested. This was one that I think shocked the community, because the public health community, because more testing is always better. When we know exactly how many people have the disease, we can actually do something about it, as opposed to having cases that we don't know about. This is especially surprising given the high number of asymptomatic cases we've seen with COVID. So we've seen lots of asymptomatic, no symptoms whatsoever. And so then to encourage people who have been exposed to COVID not to test seems like we're missing a whole category of people. Now, as you start to dissect the decisions behind this, the CDC kind of stepped back a little bit and said, okay, well, they can test if they want to, but it was more of the anti-test mentality. And I'm going to come back to why. Why is the CDC saying such things? But that actual recommendation was revised by the White House Task Force Committee. And then the CDC recommended it from the White House Task Force Committee. The second big move from the CDC more recently was to change their death certificates. And you may have seen this all over social media. It was taken absolutely in the wrong way. Because they said only 6% of the deaths come from COVID. Only 6% of people who die of COVID don't have any other underlying conditions. Now, we have to remember in America today, most people have underlying health conditions. It's rare to find people who don't, but they still died of COVID. So that's diminishing the impact of this disease on society. One of my favorite memes on social media after this was said, was actually the Titanic sinking. And it said, oh, well, she didn't drown. She actually had diabetes, so she would have died anyway. That's kind of the mentality here, is these people weren't about to die, but COVID caused them to die, even with their comorbidities. But the diminishing factor of the true impact. So why would the CDC do this? Why would the CDC come up and say some of these things that are not directly aligned with public health? Well, we know that their funding comes from the government. I have to be honest, I've never really thought about this deeply before COVID, but to realize the political influence into our public health information. So our public health information, here's our source of good health information. I've told students for years, the CDC is a great source for information. And yet what we start to see is that they have some political influence, that they're allowed to say things or not allowed to say things. Now, if I could get into the ethical point of view, I've thought, if I were director of the CDC, how would I handle this? It would be very complicated. That's why I told you how many employees. We're looking at 15,000 employees at $11.9 billion. They don't just focus on COVID, they focus on every chronic and infectious disease. And so if you have all of these programs in various health avenues, and your funding could be at risk if you disagree politically with what the agenda of the nation, then you risk funding to all of your employees and funding these critical programs. So I think it's really interesting to see that political overreach, that sometimes it's the whoever's in office has the ability to dictate our public health information, which in my opinion should not be happening, because then we don't have quality public health information. Who do you trust if we can't trust the government agencies? I think that COVID has been a pretty big hit for the CDC and their reputability in all of this. So it's an interesting idea of how else could we set this up so that they're not government funded. We've seen the CDC at risk for financial cuts multiple times. It depends on who's president, who's in power. The pandemic response team was fired a couple of years ago. It might be a strong statement. They were combined with a different office, and the director of the pandemic response was moved into a different position. And so we can see the political influence there. Now, as I start to wrap up here, I want to give you one final thought, maybe a little horrifying. I'm not trying to scare you here, but the FDA is also government funded. And here we are in an election season, and we have a president who is vowing to get a vaccine out by election day. And that is one of his big campaign promises. We're going to have this vaccine out. It's going to be available. The FDA is also government funded, which makes you wonder what kind of overreach we have there as well. So I want you to think about that idea of health as not a political issue. Can we focus on the health of individuals and not focus on politics? Just what is good for people and not what is good for the political candidate or the political party that's in office? And how do we get back to true public health and protecting the population? So I appreciate you being here with me today. I'm happy to take questions after we're done. Thank you.
All right, thanks so much, Sue. So lastly, we have Kim Bennion, and then we'll go into our Q&A session.
Hi, folks. I'm so glad to be able to be here with you. I apologize for my camera not working, but as a registered respiratory therapist for over 40 years, I think we're living in unprecedented times. Terry Guillemets once said that the wisest one-word sentence was breathe. And I think that's been hard through 2020 with all the challenges we've had, but that is specifically a challenge for many people who turn COVID positive. I wanted to speak on what we've done within Intermountain, because we have faced moral and ethical dilemmas that have been addressed so well by the previous speakers. Intermountain Healthcare is comprised of 23, soon to be 25 hospitals, over 45,000 employees, and about 220 now physicians' offices. So you can imagine the magnitude of trying to mobilize equipment, staff, et cetera. The first thing that we were asked to do was a vent inventory. All ventilators, mechanical ventilators that do artificial ventilation, they aren't all created equal. Some can manage the very sickest patients who have adult respiratory distress syndrome as a result of COVID or a number of other conditions. Others cannot. Vice President Mike Pence requested that every state report up how many ventilators they had and what those capabilities were. I think it's that brought the field of respiratory therapy really in line and visible to people across the nation. We sent New York and New Jersey had their big boon. We were kind of benefactors on the coast. As the coast were hit so hard, we had the opportunity of a little bit of a delayed spread time. And now we've been able to learn from them what it looked like, how to care for it. We sent a delegation, a multidisciplinary team that included respiratory therapists to New York and New Jersey, and just learned a profound amount of information that we were able to benefit from and apply here. We were part of the National Institute of Health guidelines for how to adequately handle ventilator patients. And with that, looking at how will we resource this? Within these 45,000 employees, we only have 650 are respiratory therapists. So we realized very quickly we could run into a real shortage. And so these highly technically skilled and educated therapists dealing and who have historically helped deal with in all of the ICUs, the most critically ill, might be a short. So we began telecritical care and put respiratory therapists at that desk so they could have oversight and guide some of the care across our ICUs. One person helping guide this for the boots on the ground, so to speak, the nurses and the therapists and the physicians at the hospitals. Then we had tons of supply substitutions. And the one that impacted the dilemma for some of our staff was the fact that before N95s we had strict guidance about how long you could wear them. And now they were saying, oh, you know what? We're going to issue you 2 N95s and we're going to take them back and clean them with hydrogen peroxide, which you heard Dental Hygiene speak of earlier. And that was a real dilemma for the staff. They wanted to take care of patients, but they wanted to be safe for their families as well. So that was one of those moral dilemmas. Respiratory therapists within our organization, many are trained for advanced care planning discussions. If those had not happened earlier and we knew if a patient wanted to be resuscitated or intubated, if we had had those discussions, that was great. But if we hadn't, and now the patient was intubated, we had to reach out to their family. And did the family really understand what the patients wanted? And that could have been a really high moral dilemma. I'm thankful that because of what we've learned from the coast and because of some of the NIH guidelines and other programs that we had been participating in for years and years, we have not seen the surge. Some folks on the coast were intubating everybody. Other folks were not intubating anybody because it was aerosolizing the particles, aerosol generating. We were very conservative with intubation and have been able to keep people from being intubated. Not all, but we aren't seeing the number of intubated patients and ventilated patients that we saw on our coasts. Human resource management became a huge thing. I think forecasting in healthcare, the ability to forecast is so important. So I think what we did in the fall of 2019 became a lifesaver for us. In tandem with Utah Valley University, we instituted the first national RT-AID program. It was a 5-week course, kind of like a CNA or an MA. And we were able to have these people now at our disposal, not knowing that the pandemic was coming at all, but they were runners and stocking equipment and bringing us supplies. So that was really a godsend. We worked with our Division of Professional Licensing to see what other licensed professions could cross-train besides nursing. And we reached out to our physical therapy counterparts and did some training, just planning for the surge that we're now seeing kind of have a second wave. We did a skills inventory of all of our respiratory therapists because a newborn ICU therapist isn't the same as an adult therapist and isn't the same as a life flight therapist. And we began to mobilize who and how the process would be for us to share staff among all of our hospitals. Then there was a dilemma of medication management. We were running out of medications on the coasts. So we said, all right, how will we decide who gets it and who doesn't get specifically respiratory medications like albuterol, inhaled steroids? And we really figured out very quickly that we needed to document medical necessity. Did they fit the meet or not met criteria for being benefactors of it? If it wasn't going to work, we were just going to do a shotgun blast. Everybody gets albuterol because they're having trouble breathing. That doesn't always help in all situations with breathing compromise. And so we came up with a well-devised plan and educated people about that. What we learned was that there was power in planning ahead. Most of this just took fine-tuning because we've been doing it for years, but we fine-tuned it to meet the needs of this specific pandemic. We found that we could mobilize quickly, that we could effectively work from home if we weren't doing direct patient care, and that we could use information technology that we had kind of shunned before. And then I discovered personally that I stand on the shoulders of some pretty phenomenal respiratory care frontline leaders. In the end, when all this gets done and said, I think it boils down to this. If you can't breathe, nothing else really matters. So we need to help our patients breathe, but we need to help our frontline staff breathe too. Whether you're a nurse, a doctor, a lab technician, a dental hygienist, a respiratory therapist, sometimes we have to just let them breathe. So we began doing a lot of things to show appreciation to our staff. I hope they realize that and realize the power of those frontline health caregivers, because they really are the superheroes. They're exhausted, and we found very quickly we needed to find ways to help them take a break. Thanks so much for joining us today.
Okay, thanks so much to all of our panelists. We're going to go ahead and go into our Q&A session. We do have a lot of questions. We'll try to get through as many as we can, but we may not be able to get through all of them. But Marcy is going to go ahead and start our Q&A session, and maybe the presenters can also type some of their answers into the chat box while other presenters are answering questions. Okay, Marcy.
Okay, can we get the presenters to turn their videos on? And then a lot of the questions will impact, I think, pretty much everybody to respond. So the first question will be, how do you see healthcare moving forward after COVID? When do you think it will get back to normal, if it will get back to normal? That question can be for anybody.
This is Kim. I can take that one on. I don't think we will ever be the old normal. We will be a new normal. I think we're smarter. I think infectious diseases in general will be forever altered, how we take care of them, how we apply PPE, our personal protective equipment. I think you've seen it with the dental hygienist that spoke today, adapting all kinds of things so we can assure the safety of our patients, but also of our staff and our healthcare givers. I think telemedicine is here to stay. When we put respiratory therapists at that telemedicine desk, now CMS, Medicare and Medicaid, 2.5 weeks ago said, yep, we're going to let them have a seat there, which they had not done before. So I think it's just a new day, new way. And I think we will be better having gone through this.
And I can jump in there with when, this is the crystal ball question I get almost every day of my life. Like, when is this ending? Let's say we do have a vaccine. I hope it's not by election day, because I don't think we're ready for that. But maybe I've heard the health officials say early next year. So if we have a vaccine early next year, it will go to emergency responders, essential workers first, then the elderly population, and then it will slowly trickle down into more average risk people, and then into children once it's tested in children. It's not being tested in children right now. But I do think it's not going to be over when that vaccine is created. People think that that vaccine's created and we're done. We're probably a good 6 months to a year after that vaccine is created for everyone to get it and for immunity to be high enough. That's assuming we keep immunity to COVID and we don't need continual boosters, and that the vaccines work. So there's a lot of unknowns still.
Okay, awesome, everybody. Thank you for responding to that. I'm gonna pose the next question directly to Karen. The question is, how many dental offices are currently using the third arm?
Well, not many. I'll put it that way. There are some practices that they have a hygiene assistant that can help with the high vacuum section. But I would say the third arm is just like a local little invention. And so I would say that probably not many. Maybe they have the patient hold it. Maybe they have, like I said, an assistant, or maybe they're just not using it, or they're completely not using the ultrasonic at all, which I think is unethical actually for practice, when you have the ability to really decrease a biofilm in someone's mouth and improve their overall health with this ultrasonic. So I would say not very many. We've had schools call up and say, what are you using? Are you using ultrasonics? And if you are, how are you doing it? And so I feel like we're a little bit novel on this with this high-speed section in the third arm.
Okay, awesome. Thank you, Karen. I appreciate you answering that. The next question is from Carter, and he's stating he sees lots of statistics claiming that the fatality rate of COVID-19 is far less than 1%. Is this an accurate statistic, or is there hidden data that isn't factored in?
Yep, that's me. I'll take that one. So the problem is that the fatality rate differs depending on where you're at. And I haven't done it for maybe 3 or 4 weeks, but I've done before every state and every country and their fatality rates. And they're everywhere from, the less than 1% all the way up to, I think we have some countries that are closer to 10% fatality rate. So the basic equation for a fatality rate is the number of deaths over the number of cases, and it's a percentage. The problem is when we don't know how many cases we have, that inflates our fatality rate. And so with asymptomatic cases or not testing enough people, then our fatality rate can get skewed. And so right now we have this huge range of fatality rates, and so it's hard to narrow it in. 10 years from now, we will know exactly what the fatality rate is of COVID, which will not help us at all right now. But it's one of those things where we're trying to do the best information we have. Utah has a really low fatality rate. And so I get that a lot of people look at that and say we shouldn't have the restrictions we have. One of the things I've been trying to share with people all throughout this pandemic, we need and statements. It's not that it's bad or good. It is. COVID probably won't kill you. Most people are recovering from it. It's got a pretty low fatality rate. And we've had over 200,000 Americans die from this disease. We have to use and statements. It's not either or. It's probably not going to kill you, and a lot of people have died simultaneously.
Awesome, Sue. Thank you. All right, let's move on. The next question is going to be from Tanya. And I believe this one came up when David was speaking. So the question is, people are becoming polarized over masks, and it's so divisive. What can we do to have more masks be focused on health and less on politics?
I think we need to learn how to talk to each other and to listen to each other with humility. I think we need to, we just have to be able to see other people's perspectives, because these situations are always messy. The tension between individual rights and public welfare, public safety, they're always messy. We're going to have to trust that people are doing the best that they can. I wish I had a simple solution to that, but I never found a simple solution that worked here for anything.
Okay, awesome. Thank you, David. Here, another question is, does the World Health Organization, let me rephrase that. The World Health Organization, is it a credible source to rely on? And what is the difference between the World Health Organization and the CDC?
Sorry, having a hard time unmuting here. The World Health Organization is funded by its member states. So there is some political influence, as we've seen, as the United States has threatened to pull its money and pull its influence and not be a part of the WHO. So it's not completely unbiased of political influence. It's going to have more balance because you have all of the member states coming together and talking. So one individual country is not going to have as much of an influence. Now, when I say that, the US does fund the largest share of the WHO. So it is going to have somewhat of that influence, where the CDC is primarily, it's the United States. They have an international focus, but it is entirely funded here in the United States.
Okay, awesome. Awesome. Thank you. The next question is a statement, then a question. In places like Michigan and New York, COVID patients were cycled into nursing homes where some of the most vulnerable people were. Who was it that thought that was a good idea? That's for anyone.
I think that none of us are answering because nobody thought it was a good idea. I can't tell you who exactly made that decision. But one thing to remember is that in a pandemic response, that in public health and nursing and dental hygiene and respiratory therapy and all of our professions, we are dealing with something we've never dealt with before. I mean, it's kind of that unknown, where it's not like we do pandemic planning and response every single day. This is kind of an unusual situation, and people are doing the best they can with the information they have. And sometimes they're going to pretty badly botch it, which it sounds like happened there.
Well, I'd like to mention that for dentistry, we've been through this before back in the 80s. I mean, remember, there was one time we didn't even wear gloves, yet alone eyewear or masks in the 70s. And so when the 80s came around, they started with the AIDS epidemic that pushed us into using masks and eyewear and gloves. I mean, my first year of dental hygiene school, I went without gloves. It was, quote, optional. And then the next year it was thinking, well, they was still optional. I said, I think I'm just going to wear the gloves because I can see the writing on the wall that this is going to be something that is going to change forever in dentistry. So for now, I couldn't even imagine going into anybody, not even my own family's mouth without gloves, so it's just things that change. And so that was one of the biggest changes with our field. And I can see, again, with the COVID, another big change is we just had to up our PPE and get the high backs in there and, think a little bit more about our surroundings when we work.
So it looks like we are almost out of time. So I just want to ask the last question. A few people asked how medical settings and hospitals are now doing with supplies, PPE and masks and things like that. How are you guys doing with your supplies? Do you have enough at this point?
This is Kim. I can take that one. Yeah, I think we had stockpiled. I don't mean unjudiciously, because we were being even regulated by vendors nationally. But I think we're doing better. We are still reusing masks, our N95s, and so I think we're better. I think our PAR levels, the minimum that we will keep, will increase. That's one of those things that will change to the original question. we'll keep more of those. We're doing fine. And in Utah, we're doing very well. And we don't have the number of patients going on ventilators and being in our ICUs, because I think we're doing some other earlier interventions that are helping, like high flow nasal cannula, et cetera. So I think we're doing better. And I think we do not have to worry about a shortage of equipment and supplies at this time. However, as soon as you say that, we may see this big surge, and we just have to prepare for that. And we have a strategic plan in the background.
Great. Okay, looks like we are just now out of time. So we want to thank all of our panelists for sharing your wisdom and expertise with us. And we'd like to thank all of you for joining us to discuss more about COVID-19. Thank you for all of the great questions that you've given. And we hope to see you at more Ethics Awareness Week events today. But thanks again, and we will see you all later.
Sarah, that was a great